Good afternoon, everyone. Today's presentation is on recent advances in VT prophylaxis and the latest evidences which we have gathered. I'll be talking about those. In my presentation, I'll talk about VT risk assessment and pharmacological thromboprophylaxis. I'll talk about mechanical thromboprophylaxis and future what what is pending for us to come. To begin, we'll start with the global burden of the disease. We know it that hospital associated VT is occurring during hospital admission for up to 90 days. Then we know that unfractionated heparin was introduced in 70s to 80s and it has shown promise that it can reduce VT. But during last decade, newer oral anticoagulants, which are directly acting, were introduced, and even factor 11A inhibitors, which I was not aware before preparing for this presentation, was introduced. So I'll talk about about it in my coming slides. Then WHO is planning to introduce VTE risk assessment to every hospital as a universal risk assessment tool. So maybe in near future we'll be able to have something very common all over world, that is risk assessment tool. Then as incidences are more and the burden of disease is so high that we are losing about 10 million people in US alone. That is the data from US. So meaning if we have some tools to assess risk and then we can introduce our prophylaxis at time, maybe we would be able to reduce the burden to certain extent. But for that, as we know that there are several tools in our hand, including wells, WHO's uh, Reuters, Geneva, NICE guidelines, Caprini score, Padua score. There are so many scores available for assessing simply the risk of venous thromboembolism in our patient and then introduce our prophylactic agent. So, what is the general idea is like if we give to all our patients prophylaxis, it will just reduce the VTE by 60%. Even after starting the prophylaxis, you'll get 40% who may turn up with DVT or pulmonary embolism or together. So that means no model is foolproof. And why we are worried more is if we introduce prophylaxis, some patients may go to the other side. That means they may bleed. So we need to risk assess both the chances of venous thromboembolism on the one hand and bleeding on the other hand. It is not simply looking at one arm and introducing your therapy just basis that risk scoring system. We need to have something of the other. And then there are models which aims to identify patients of VT risk. Two approaches, qualitative as well as quantitative approaches, have been in vogue since last 10 years. We'll talk about those. So we have American Society of Hematology VT prevention guidance, and they have reported on about 15 types of RAMs. RAMs are risk assessment models, meaning at least 15s are available. So, which to use when is becoming a bigger question than. So, it is a problem of plenty. Then they have mentioned about Caprini, Geneva, Improve, Kusher, Padua, and all have their advantages and disadvantages. Basis the group of patients they are trialed. NIH supported review evaluated about 24 RAMs, meaning it's not 1, 2, 3, 4, but 24 risk assessment models available. Which to use is a bigger problem. There have been various validation studies, but since the studies have several bias and the population is heterogeneous, nobody reached to one conclusion that which score should be the best. Rather, they'll say for such and such patient, use such and such RAMs. These are those scoring systems. Started with Caprini and Kusher in 2005 to improve in 2011. If you look at them, Caprini, Kusher, Geneva, ACCP, NHS tool, Padua, they are all risk assessment models for VT, DVT, and pulmonary embolism. The only model improve is basically a bleeding risk scoring. So improve is the only validated tool to assess bleeding risk. If you look at the characteristics of all the risk scoring systems, few are done on medical patients, few are done on medical plus surgical patients. So, for example, if you have a surgical patient, which tool would you like to use will depend on mostly people nowadays say Padua as a medical risk assessment tool and Caprini as a surgical VT risk assessment tool. So surgical patients usual trend is to follow Caprini score. So now I'll talk about risk assessment in orthopedic patients. So as we know, joint arthroplasties like knee replacement, hip replacements are the highest risk for VT, and even now that we have developed as an anesthesiologist and there are techniques evolving with help of technology, the surgical dissections are getting lesser and lesser, so the risk in a way is going down and down for VT, and there are several scores which are being proposed particularly for particular field. For orthopedics, as I have mentioned here, trip plasty is for arthroplasty, for joint replacement surgeries. There is another trip cast, which is where lower limb injuries, plasters or casts are being applied. So the risk assessment model in these two are different. They are based on clinical parameters as well as lab indicators. So as you look into this, when you have a lower limbs injuries, 2% of lower limb injuries requiring immobilization develop DVT without thromboprophylaxis. Meaning if you have casted 100 patient, 2 is going to develop DVT. These two studies basis podcast, they have tried looking at whether if I introduce thromboprophylaxis, would it be of any help or not. And the first study, podcast study, have found that even with the introduction of thromboprophylaxis, there is no change in the rates of DVT, questioning the entire concept of introducing prophylaxis. Whenever we introduce VT prophylaxis, we in our mind are clear that now my patient is not going to have DVT, at least because I have introduced prophylactically before the event. But as all prophylactic therapy, this also is failing in trials, meaning even on prophylaxis, not the bleeding risk, which is the other side, the efficacy of drug in particularly in patients who are having very low risk of DVT, if you apply or introduce treatment, it won't help. That's why risk stratification is important, and we introduce only when we have intermediate to high risk, not in low risk, because there won't be any benefit at all. Like this podcast trial, which is done on orthopedic fracture surgery, fracture patient who have been applied cast and immobilized. And tripcast score, as I have discussed, was developed to aid orthopedician applying thromboprophylaxis, particularly where they have casted their patients, like the podcast study. And there they find if the scores are more than 7, if they are high or intermediate risk, then it is benefiting. So with this, now I'll move on to risk assessment in cancer patients. As we know, cancer patients have increased propensity to clot. So I'll be talking about Khurana score, which is widely in practice, but It is only for ambulatory cancer patients, patients who are walking. It's not basis hospitalization. Even hospitalized patients, if they are walking, then it has been validated in such patients. But there are many things which it doesn't account, like the chemotherapy, what is going on, the type of cancer, what the patient is having. So there are several modification of Khurana score, like Vienna CATS, Protect, which I am going to show in my next slide. Particularly in multiple myeloma patients, they don't uh, fit more into Khurana score. So there are different risk assessment models for multiple myeloma, and they use like SAVED, IMPEDE, VT, and PRISM score. I'll be talking about or showing a slide for them in my coming slides. As you see, Khurana score is based on cancer subtype, which they have scored 0, 1, 2, and then pre-chemotherapy lab indicators like platelet counts and white blood cells. So they take an average of 3 and then score it. Any score more than 2 is an indicator to introduce thromboprophylaxis. So, meaning a cancer patient, we need to introduce thromboprophylaxis. Now, several modifications are like this, where you have additional lab tests to help you is D-dimer and P-selectin. If they are there, then you can introduce these two lab tests and modify Khurana. If you have chemotherapy regime like if you have cisplatin, carboplatin driven therapy, then the score is further increased. So these are several modifications for particularly for cancer patients. Then this is what I have talked of about multiple myeloma patients. Saved VT trial, VT risk factors. It is a further modification of Khurana score, which is particularly used for cancer patients. This is further another modification on Khurana score, and they took into account patient specific risk factors and cancer specific risk factors, and they added on those Khurana scores, particularly for multiple myeloma patients. Now, coming to what will be the therapy or prophylactic therapy for patient who is acutely medically ill, like medical patients coming and getting hospitalized. This was a landmark trial which was published in Chest. This is about improved trial. It is popularly known as improved trial, and this is bleeding risk screening score rather than thrombosis risk score. So it is looking at the other side of introducing a prophylaxis. And what it found, though it is validated for acutely ill medical hospitalized patient, but can we apply it to surgical patients where it is highly required? Because surgical patients are the patients who are at risk of bleeding, and they are at risk of thrombosis as well. So the utility of improve has never been validated in surgical patient where it is required the most. Though there were several attempts, like if you look at the top, the first attempt was a Chinese trial, which is they looked into the cohorts of patients of this dissolve 2 study, which was a huge study. They looked into only cohort of patients where they have and gone for surgical interventions, And what they found is it has good predictive power for major bleeding, particularly in patients undergoing abdominal surgery. So now for abdominal surgery patients, you have some tool which will assess bleeding risk as well, validated for abdominal surgery. But this recent trial in Journal of Vascular Surgeon Venous Lymphatic Disorder published has shown that it has a low ability to predict bleeding within 90 days of admission. Meaning, earlier Chinese people tried to look at the surgical patients, a cohort of surgical patients, they took it from the other trial, which was a dissolved trial, and they found that surgical patient improve is doing good. But they have looked to follow up the patient for 14 days only. Now, this paper, they looked for 90-day follow up period is 90-day, meaning 3 months. And what they found is, though there is association between the improved high score and bleeding risk, but doing a improved on one patient and predicting that he will bleed, there is nothing like that. The performance or the predictability is not there in this improve score. So then how to utilize it? We can utilize it for hospital purpose. We can introduce improve score as a chart to nurses, but we cannot predict that if the patient has a high improve, he's going to bleed. He may not. So that's the problem with improve. Now I'll talk about pharmacological thromboprophylaxis. Moving ahead and going to thromboprophylaxis per se rather than risk assessment models. So as we know, the drugs we are using, they reduce VT risk by 60%, as I have discussed. 100 patients you treat or give prophylaxis, they'll reduce the burden by 40%. 40 people still may have VTE even after medication. And the chances of bleeding, we need to assess it before giving the thromboprophylaxis. It is not only simply looking at the VTE, rather we need to look at bleeding risk as well, and then combining together, we must start our prophylactic therapy. As we have seen in COVID pandemic, there was a lot of uproar about increasing the dose of thromboprophylaxis. Highest dose is going to go better. But in the trials, they failed. In the trials, it came out that only the standard dose is working, and there were cases where it hasn't worked even after supranormal doses. Particularly if we look at acute medical illness, they say there was one trial which was done and which showed that intermediate dose low molecular weight heparin has a favorable risk benefit profile in about 1 lakh, more than 1 lakh patient database. So what is intermediate dose low molecular weight heparin? If you have enoxaparin dose of 40 and above milligram per day, it is considered to be intermediate dose. So 0.4 ml per day is an intermediate dose. So it has shown that 0.4 is doing better than low dose. Secondly, in those trials, the latest of trial which was done in medically ill patients, what they have found is it is this particular subset of patient, medically ill patients, who are going to have thrombosis most often, rather than surgical patients going into thrombosis most often. So what they have done is they tried to look at the cost economy of it. And what they found is For medically ill patient, need not do any risk assessment model for VT, rather give to all medically ill patient as a prophylaxis. That will be cost beneficial. Then doing a model and then applying it for medically ill patients. Then will come. And this was a research published in 2022. And what they have tried to look at, the agent what we are using, like low molecular weight heparin, either in low dose, intermediate dose, or ultra unfractionated heparin, low dose or intermediate dose, pentasaccharides like fondaparinux, directly oral acting anticoagulants, and no intervention. So this chart is showing, the white portion is just telling the mortality, and this shaded portion is showing the risk reduction in VTE. So if you try to look, this is, the numbers are odds ratio. So if there is risk reduction, it should be less than 1. So if we look in the shaded portion where we are trying to look at risk reduction with particular agent, then you could find that it is intermediate dose low molecular heparin which is overall reducing the risk rather than any other choice. So no fondaparinux, no unfractionated heparin, no directly orally acting anticoagulants, or placebo. So now with this trial, which was published in 2022, enoxaparin or dalteparin or nedroparin, they are all low molecular weight heparin. If they are used in a doses 0.4 ml or 40 milligram and above, they are beating all the other available for acutely ill medical patients. So this database is the largest, and it included about 14 studies, 14, not 1, 2, 3, 14 studies meta-analysis. So this is now a firm thing that for medically ill patient, low molecular weight heparin, be it whatever of your choice, inoxa, delta, nedro, use those over others. About COVID-19. As we know, COVID thrombosis was immune related thrombosis. So whatever studies and the major studies were done, they indicated one and one thing only, not supranormal dose, not low dose, rather standard dose of therapeutic drug to be used. And it has only helped those who is not severely ill. Meaning, if a patient of COVID has entered into ICU, is on mechanical ventilator, is on organ support, for example, dialysis or other things, they are not going to get benefited with the introduction of VT prophylaxis or anything. It is only the less severely ill who is in the ward or in the ICU, but not on organ support, rather on oxygen therapy, they would have benefited. Meaning, severity of illness, and second thing is BMI. Two things have predominantly come out. They say if you have a high BMI and you are severely ill needing organ support, then they have not benefited by prophylaxis or therapeutic dose of anticoagulants. What about critically ill patients, which we see? So, for critically ill patients, usual practice is to use unfractionated heparin over low molecular weight heparin because it could be given as an infusion, it could be reversed, and it has a shorter half life. So, in ICU, we need something which we can control a bit so that if any mishap occurs, we could actually reverse it or stop the dose. That's why unfractionated heparin is in practice, but the guidelines say the opposite. Guidelines say low molecular weight heparin is more efficacious than unfractionated heparin, but there is no difference in the bleeding risk. So it is only the efficacy, safety wise, they are both same. This is about Protect trial, the other arm. Protect trial was for, they have a huge database of patients on DVT prophylaxis, a subset of Protect trial patient where they have creatinine clearance of less than 30 ml per minute. Particularly those subsets are retrieved, and then there the low molecular weight heparin of choice was dalteparin, which has nothing to do with kidney, so it can be cleared outside of kidney. So it was the safest drug to use in low creatinine clearance patient. This was used, and they are found more efficacious than enoxaparin. So dalteparin only for patients who have low creatinine clearance, who are critically ill, dalteparin is better than enoxaparin. This was the trial. The data, this was not a trial but a meta-analysis, and it was about 14.
So far, we are using right now is enoxaparin. हम लोग तो
Enoxaparin.
deltaparin available in India.
Deltaparin is available by the name of Fragmin. Pfizer is the only company which markets it. The second trial, which looked into cost efficacy. One interesting fact which I need to tell you all is there is a difference of rates in UK and USA. USA, unfractionated heparin is cheaper. UK, low molecular weight heparin is cheaper. So if you have read a UK guideline or a UK database, they would preferably give low molecular weight heparin because it is cheaper than heparin in UK. So this trial, why I have picked it up is because this is an US trial, not a UK trial, and they say it is cost efficacious to use low molecular weight heparin over unfractionated heparin, even though unfractionated is cheaper. And the database which I have picked to demonstrate is what they have shown is looking at the total hospitalization cost and all the cost. If you look at the unfractionated harm heparin prophylaxis, cost is more for unfractionated arm patients, and they have looked and followed up their patients for 90 days post admission. So they concluded that it is cheaper to utilize low molecular weight heparin, though it is at more price, but overall it reduces the cost of therapy for particular patient, because if patient is getting admitted within 90 days, then the cost of therapy is going up. So this is a US trial, mind it. Now, about ambulatory patients with cancer, where risk assessment tool I have discussed is Khurana score, validated tool. Before before the trials which have used rivaroxaban and apixaban in cancer patients, earlier it was dictum to use low molecular weight heparin over any other agent for cancer patient because data were lacking. But rivaroxaban trial and apixaban trial in cancer patients have proven that they are better than low molecular weight heparin to reduce VT risk in cancer patients as well. And hence, American Society of Hematology guidelines recommend DOACs for high risk ambulatory cancer patients. It means not low molecular weight heparin, not unfractionated heparin, but a tablet or a capsule for cancer, which was not there. So it's a recent update. What about surgical? As we know, surgery is completing one arm or two arm for virtuous triad, which is a risk factor for thrombogenesis. What meta-analysis have shown is DOACs and LMWX low dose are equal. Meaning, if you have a patient whom you have risk assessed and found that there is a high risk of thrombosis and low risk of bleeding, you can use any. It is not that now you have to use only low molecular weight heparin because they are admitted. You can start with oral agents as well.
Cost difference between oral and this?
Oral would be far cheaper than low molecular weight heparin. Far cheaper. 10 capsule will cost to 1.
And compliance is very easy.
Compliance is very easy, no prick. What about DOACs and cancer surgery? We know that ambulatory cancer patient DOACs are better. So what if in cancer patients who have been operated upon and then after a few days of admission, they are discharged? So the concept is if you are extending the therapy of DVT prophylaxis or not. Several trials have tried to look into that aspect and they were like ambiguous results have coming up. Some trials are favoring use of extended thromboprophylaxis, which is after hospitalization thromboprophylaxis, and some are saying it is showing no benefit even after using extended thromboprophylaxis. But American Society of Oncology, they suggest in their guidelines to use either rivaroxaban or apixaban, which is another oral agents. What about DOAC use in orthopedic lower limb surgery? Meta-analysis have shown that DOACs are superior to low molecular weight heparin in preventing DVT without increasing the bleeding risk. Categorically, for orthopedic patient, DOACs.
DOAC may be which medicine?
Apixa and rivaroxaban both are being tried. What about aspirin use in orthopedic surgery? Lots of orthopedicians are using it. So aspirin in orthopedic replacement surgeries pre and post have been used in 2 or more than 2 trials, and they showed some benefits over not using any thromboprophylaxis. So it is easy to understand that if you are not using any and using ecosprin is performing better than placebo. But people try to look at it and do some trial to find out whether they are of any use in arthroplasty or in comparison to low molecular weight heparin. So what they found is again the same thing. In one trial, low molecular is better than aspirin. In other, aspirin is equivalent. So the question remains, and the question now push you further to think of personalization of risk assessment and personalization of therapy for individual patients. Meaning, if you have high risk, if you have risk scoring system and it tells you have a high risk, you may go for low molecular weight heparin. If you have risk scored and it is a low risk and there is low risk of bleeding, before that I must tell you that today I learned a new thing. The thing is, conceptually, if a patient is on ecosprin or antiplatelets, what we do is we withhold a drug for a day or a 3 and then do elective surgery, considering that the patient might bleed during operation. So it is our presumption that aspirin cause more bleeding. That's why we push the surgery for 2 3 days post. But the concept is wrong. It has been proven that aspirin doesn't increase the risk compared to what? Compared to anticoagulants, compared to warfarin, compared to rivaroxaban, compared to apixaban. So aspirin does not increase the chances of joint bleeding, particularly in orthopedic surgery, as well as if there is no bleeding, the chances of infection going down. So this I have discussed about extended pharmacological thromboprophylaxis, meaning after discharge thromboprophylaxis. There are patients or a subset of patients where it is recommended, but it is not universally recommended for all your patients. Multiple trials have tried to study it, but they failed. The only agent similar with the 10A inhibitors like rivaroxaban, apixaban is betrixaban, which was FDA approved for extended prophylaxis, but European Medical Agency have not approved it, and hence the drug has been withdrawn from the market. So now you are not going to get betrixaban, which has which was the only trial which came positive for extended thromboprophylaxis over low molecular weight heparin. What about mechanical thromboprophylaxis? What about those patients where your risk assessment of VT is high and bleeding risk is also high? Are you going to use the thromboprophylaxis? Probably no. Then what is the answer? What we are left with is some other ways, non-pharmacological means to manage those patients, and they are mechanical thromboprophylaxis. Though UK studies which have assessed about anti-embolic stockings like TED have not shown any benefit except intermittent pneumatic compression devices, which have benefits only for stroke patients, thromboprophylaxis. And about elective surgery patients, like you are going to operate, you see the risk is high, what will you do? So graduated compression stockings, like we know the pressure is high at the ankle, low at the calf level, and lower at the knee level. Those are graduated compression stockings, which we say level 2 or for varicose and others, they have shown no benefit in surgical patients when there is a chance of bleeding. Meaning, now using DVT pumps, which is intermittent pneumatic compression device, which is pumping the calf from low to up in a sequential fashion, have only utility in some patients who can be benefited, particularly in stroke patients, medical patients, not in surgical patients. Meaning, if you have a joint replacement, DVT have not shown any benefit, DVT pump have not shown any benefit for preventing thrombosis. These are various trials amongst several surgical cohorts.
So IVC filter could be one of the
IVC
mechanical.
IVC filters are not to be used commonly because what they do is they prevent the clots already formed to enter into right atrium.
Okay, so
But
here the clot is
but
already there. Yes.
but if the propensity to form a clot is high, the whole IVC may block your flow of
Yes, why not? This is very good. Surgical prophylaxis is good.
I'll leave about obstetric thromboprophylaxis, pregnancy and postpartum. And
No, so this is a very important aspect. And we are going to cover in
separate thing,
class.
yes.
Okay.
So now the most important and the most latest of agents which are introduced elsewhere, not in India, and they are factor 11 inhibitors. Factor 11 inhibitors, which we have no idea that they are being trialed for prevention of thrombotic events and DVT and PE. There are 4 trials which have looked into it, and there are ongoing trials. They are in phase 2, phase 3, where they have tried using it knee arthroplasty. And what is the advantage of factor 11 is they are particularly important for surgical patients who bleed after DVT prophylaxis. So the bleeding risk is very minuscule in factor 11 inhibitors. That's why they are being promulgated, and several trials are on way. Maybe in 1 or 2 years, the trial reports and results will come up and help us to. So future research and studies which are in progress, I have highlighted about a few things. Several NIH funded research are ongoing on this particular DVT prophylaxis and thrombosis. So I hope I have cleared few of the doubts and few of the updates which have come up in recent years. There are a lot to be done, particularly several trials are coming up. They are trying to relook the results of observational trial, and maybe in future we have a better guidelines, better knowledge to help ourselves. So with that, I'll end. Thank you.
So can you make